everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today our guest is Dr. Laura Mannery, and she's going to talk about the McKenzie method's role in medicine in general and why she's passionate about the method. Laura has been certified in McKenzie since 2016, and she completed the diploma training in 2019, and now she's just waiting for the postponed final international exam. I hope you enjoyed the show. Hi Laura, welcome to PT Pro Talk. How are you today?
I'm good, Mariana. Thanks for having me.
So I'm excited to talk about our topic. It's going to be a little bit of a discussion. So before we start in that topic, just tell us a little bit about yourself, your career, and how did you get to where you are right now?
Sure. So educationally, I started with my bachelor's in economics and Spanish from UPenn back in 2000. I didn't know what I wanted to do, so I moved to Asia and taught English for several years, and then did AmeriCorps for a year in the US, which is kind of like the American version of Peace Corps. And then I knew I wanted to go to graduate school, and I narrowed it down to public health, nutrition, and physical therapy. Decided on physical therapy, took all the prereqs, and then went to the University of Miami and graduated in 2010 with my DPT. I've only worked in outpatient orthopedics since then. And I got introduced to the McKenzie method years after I graduated, and then subsequently went through the MDT process, which we can talk about, and started my own practice a couple of years ago.
So my question would be, how started your interest in McKenzie? So what happened there that you decided to do it?
Yeah, so my first job out of PT school was in Naples, Florida, and my boss was certified. So I learned about it, but I can't say that I was totally intrigued. But as a couple of years went by, I started to become disillusioned with my ability to help people, which I think a lot of physical therapists who find MDT kind of experience. But I can't say I was definitely seeking out MDT. I went to a lot of courses. Institute of Physical Art, I think that was its name, North American seminars or Great Lakes, like lots of different things. The sacroiliac courses that spend 48 hours telling you how to feel an upslip or a downslip. But I ended up going to a McKenzie course in 2014, I think. And it's just like a switch flipped in my head. It was just like, wow, this makes sense. And because I had the personal experience of low back pain that I was suffering from a lot for 5 years and could immediately apply it to myself, albeit not as quickly as I would today. It took me a while to understand I needed side glides, right? That clicked. And because I saw that with me and with patients, I was like, unlike all the other courses I've gone to, unlike the theories we learn in DPT school, I was like, this actually not only makes sense, which I think is a prerequisite for success, but gets better outcomes. And so I continued on the MDT path, got certified, did the diploma. I'm awaiting my final exam for that later this year. Went to work with mentors with Mark Miller's clinic in Tallahassee, went to Peru with MDT faculty and diplomats to learn from them, and just really came to see that this was the best paradigm for understanding orthopedics. And so that's what I use, and I pursue other knowledge. I took an Adrian Lowe course this year to better address the other category. But as we know, that other category is small. And so if you really hone your skills at MDT, you're getting the biggest bang for your buck.
Absolutely. And it's very practical. You can see the results right away with your patients. So that's exciting.
Sure. Yeah. That's the hallmark of derangement, right? Is that you're able to help people quickly. And that's what people want, to not give them that option when it's there. It's just kind of, negligent.
Yeah. And so in your opinion, what is the MDT's role in medicine in general, not just chiro or PT? For example, primary care offices, emergency rooms, and so forth.
Yeah. So I've been exposed to different colleagues or MDT professionals around the country and world who are doing some pretty cool things. I think Bill Oswald was implementing MDT in the ER or was thinking about it, but hearing from people like that, it kind of gets the juices flowing that MDT doesn't just belong in PT offices, right? And then I went to work for IMC for 5 months in Tallahassee. They have a program where they put their clinicians in primary care offices to triage patients. And I think that is a wonderful paradigm that could be emulated, because so many people, and I don't know the exact percentage, but so many people go to their PCP with complaints that are musculoskeletal disorders. Yet, as you mentioned before with other guests, primary care physicians are not versed in musculoskeletal care. And that's okay, like they don't have to be. But if they're making poor decisions that lead to poor outcomes, that matters. So if you put someone who knows MDT in a primary care office, or a primary care physician does get trained in MDT and can do it him or herself, you can really change the trajectory of what patients with musculoskeletal disorders encounter. And so like, I think MDT, definitionally is a different paradigm to orthopedics. And it gets people better faster, and it gets people to the right care faster, which is the more important facet of it. So you get people with MDT training in primary care offices, in ER, so that when they come in with excruciating back and leg pain, for example, they're not put on the opioid trajectory right away, or they're not put on the imaging is king trajectory right away. I mean, I think you've had back problems. I'm not quite sure. I've had back problems. I've been treated. It's excruciating, right? It's very, very painful. And I've never had the radicular symptoms in the leg, but I know from experience treating patients for 11 years that is very, very painful in the arm and in the leg, right? So how amazing would it be if you went to the ER and someone understood that, right? So maybe they have to do an image, and maybe they have to give you some pain medication for the time being. But what if they understood, oh, this is how you fix a lateral shift. Like, I'm going to give them symptomatic relief, but I'm going to get them on this path where I can really decrease their fear that 80% of these are rapidly resolvable, right? And that's just not what people are getting. I mean, I see, and maybe you see, a lot of people who've gone to urgent cares and ERs for their problems, a lot of radicular symptoms, and people take them to those places. Like, my sister had a disc herniation from yoga in the morning and passed out due to the pain, right? I mean, these things are horrible. And I think she went to urgent care. So yeah, I think MDT, if we could create an ideal world, people who see patients when they're first injured would have some concept of how the body works per MDT. Because I'll argue that the understanding of how the human musculoskeletal system works was best understood by Robin McKenzie, plus others, but his overarching idea, I think, is really how to best understand how joints and muscles and nerves work.
Yeah, no, absolutely. I agree. And just an example, in Brazil, I had a friend that he used to do that. He was like the emergency of the patients. He was open extra hours, and everybody that had like a crisis or something would go to him. He would love that part. Here, it's a little bit different, I guess. It's not very common to have that service available. And you mentioned the IMC going to these primary care physicians. So what do you think it's gonna take to get that spread? Like, do you think that's ever gonna happen? And what do you think would have to happen in order to that be the normal or the accepted?
Sure. I mean, I'm not the best person to answer this because I'm not entrenched in the mainstream world of medicine, right? I kind of decided I couldn't take that anymore, and I had to do my own thing, and either flourish or bust. I was going to try to do it my own way and deliver the best care I could independently. But IMC, and maybe to a smaller extent, other companies are doing this that I'm not aware of. But that Michelin paper where they put highly MDT qualified outcomes-driven clinicians at the places where Michelin employees worked, and showed that they saved Michelin tire company 51% of their budget with doing healthcare provided by MDT clinicians versus standard American care. I mean, that is profound. And maybe the number isn't large enough to really get a lot of eyeballs on it. But if companies like IMC get and I think A.G. Turner was talking about this too, you have to get people where it hurts financially, right? So if you convince Amazon, let us take over your 16 warehouses and show you what seeing an MDT provider does versus your cost going to a standard clinician. I think those kinds of things will start to get the public eye on MDT. Do I see it happening tomorrow? No. I mean, I'm cautiously optimistic that it will happen, but that's what I envision actually changing things, is when big companies who are, to my understanding, taking the workforce overseas, not because they want workers overseas per se, but because they can't afford the American healthcare costs associated with workers in America. I think when you get to those companies and convince them, there's a way to reduce time off from work and costs on unnecessary imaging and surgeries and get people preventative programs. I think if you convince them of that, that's when the national public eye will start to take a little bit more attention. I can't speak to when the medical community will change because it's been around since the 50s, right? And there's good evidence for it. And I think the $1 million question is, why isn't it more accepted? And I think part of it is maybe a messaging problem, but I think a part of it is also just like people are set in their ways and there's no accountability to actually be a good doctor.
Yeah, so that will be my next question. Why do you think it's not accepted?
Yeah.
I mean,
what do you think? And what's your rationale?
I think the healthcare is structured in a way that it works for everybody that is in there. And a lot of times the patient is not the center, right? So we have to do a lot of different things through billing, through insurance, and the physician's probably the same way. So I guess it's hard to provide the care we want to provide because of the way the system is structured and the path that the patients have to go through. Here is very hard to go to a specialist because you have to go to your PCP most of the times first. So I think that for me, I come from Brazil, so there it's very different, the healthcare system. We can go straight to a specialist. I can go, it's more common, go straight to the physical therapist. Here is not as common because there people are, they're more used to cash pay, have a better service. They already know they're gonna have to pay if they want a better service, even that they pay their health insurance. But then they have the easier access to the specialist, to the PT, and they know what to look for. Versus here, I think the culture is everybody goes to the PCP first, and then from there, the PCP is going to recommend you another physician or recommend you an MRI or an injection, and sometimes not even physical therapy. So I think the system is very centered on the PCPs and the doctors, and the path it's longer, takes longer. The patient has to pass through more things. I already treat patients that they were there just because they want an MRI, and the doctor told them, if you don't do X number of visits, I'm not gonna let you have an MRI or an exam or whatever it is. So I think the path is just harder and force people to go in certain ways that are not necessarily the best way, in my opinion.
Yeah, I agree. I mean, what you're saying is that the system is not designed to create the best successful outcomes for patients. And unfortunately, I 100% agree. And like, as to why MDT has not caught on, it's such a question, because I mean, you can read a case study of shoulder patients in 10 minutes, right? And if you're not intrigued that, 4 patients with primary complaint of shoulder pain resolved in 5, 4, or 3 visits, like in the large majority of cases, that's going to be better than what you're doing with shoulder patients, right? I mean, I used to see shoulder patients 3 times a week for weeks, right? Patients with primary complaints of shoulder pain. So if that doesn't pique an interest because you just want to be a better clinician, I don't know what will, right? And that's like the easiest avenue, reading a 10-minute case study. I mean, not even having to pay to go to a course or pay for the textbooks and labor over them for a couple months. But it's really upsetting that people who know MDT are just like, this makes sense. And we're not even proselytizing a system where like our hands are magic or we're selling expensive tools. Like we're selling that patients can largely fix themselves if they're taught correctly. I mean, I think in the shoulder case study paper I'm referencing, I don't think there was any hands-on treatment of the shoulders. I think it was overpressure with IR, overpressure with extension. I mean, there may have been, obviously there's hands-on with assessment, but for treatment, there wasn't. So I think you're right. I think until there's like a different system where, people are paid to get better outcomes, I mean, at its core, then you have to rely on every single doctor in the system, every single clinician in the system being like internally driven to spend weekends at courses and internally driven to spend their free time reading and observing mentors and traveling across the country to work with mentors. And that's just not feasible. I mean, only so many people are like powered by that ethical drive, right? And so it sounds disgusting to say that most people are in it for the money, and I don't think they are. But I think, like you said, once you're in that system, you're having meetings on how much you bill, right? You're not having meetings on how quickly you get people better. And they're not keeping outcomes, right? I mean, I toyed with the idea of writing a book about how orthopedics got so broken in this country. And I was like, if I went to 100 hospitals and said, who do, say, for example, knee replacement surgery, just to pick something that's quite standard, and I said, what are your 5-year outcomes? Like, would they even have them? Like, I don't know. Like, I don't think they would, because I don't think there's anyone mandating them. And I don't think they're getting paid on those 5-year outcomes, or they're getting more patients based on those 5-year outcomes. And I think of all the things in this country that we should say outcomes really matter, like, I think medicine is at the top of that list, and education, right? Like, medicine is important because it affects people's lives in such a profound way.
Yeah, no, absolutely. And that was another difference, just talking about physical therapy now. So here in the US, the PTs, when they leave college, they can get a job and they're going to be paid to have their jobs. And again, it's usually not every place, but usually it's more like a volume-based system. And versus, for example, in Brazil, we don't have big clinics that are going to hire us and pay a good salary. So that if you want to succeed, you're going to have different skill sets and bring outcomes, because that's how you're going to make money. People are going to pay if you're good, and then the word of mouth and all of that, and then you grow. So I think, like, since the college, we're already discussing between us, like, oh, what you're going to do, what course you're going to do, because that's just the start, is the basis. And then you go and do post-graduation in osteopathic, that's different from here. You can go and be a chiropractor, which is different from here. It's kind of like specialties after you graduate from PT school. You can do McKenzie, you can do Mulligan, and then everybody's always thinking about these different ways, because they're not going to get patients, and people are not going to pay them cash if they're not good, if they don't bring results. Yeah. And I think here it's different, because people go and do these courses because they have to have continuing education credits, but they are not necessarily applying as much because the way that the system is structured. So they do McKenzie, they get certified, but on their day-to-day, they have to see 2-3 patients at a given hour, and they are not able to keep up and apply and really see the results. So I think that's one of the other big difference that changes the way the system works.
Yeah, and it would be interesting to see if we compared musculoskeletal health in Brazil versus here, like how much of this is just us assuming and making hypotheses about why things are the way they are, versus do we have data that shows that countries where that's the paradigm differ from our country? I mean, maybe. I mean, the United States is not. I mean, I think it was that recent, was it the Commonwealth study that showed that compared the United States health compared to, I think, 10 or 11 other high income, high GDP countries, and we finished last. And it's based on like access and affordability and outcomes. And we were compared to other countries that were more homogenous and smaller. So Yes, we have a diverse, 300 plus million population, but for the amount of money that we spend on medicine to come in last with outcomes in that study is just really alarming, right? So something about our system is not working.
Yeah, no, absolutely. And that's another question that I ask myself, why here the healthcare is the way it is? It's like one of the richest countries, and it's still hard to have access, and everything is so expensive, and it's understandable why people don't want to pay cash pay for services, because they pay already so much on their health insurance. And every time they go, they have still to pay copays and deductibles and all of that. It makes much harder to have that access to a better service. And I just don't know why in Brazil, that way poor than here, third country. I don't know how you say the third.
Third world country, yeah.
Yes, exactly. That's it. We have free healthcare. It's not perfect, it's not very good, but people have access if they need. I mean, I'm not gonna talk about the whole country. I'm from South, so there I know many people that need services and they had it for free when they need it. Sometimes you have to wait longer than other times, but still it's a possibility. And here we don't have that option for the most part, right? And it's everything is expensive. So that's another point that I don't know if it's going to ever change or how it's going to change.
Right. I mean, I think if I write this book that I'm, late at night, I think about, I'd like to know more of the history. Like, when did we diverge from Western Europe, where they were like, oh, we think health is really important, we're going to subsidize healthcare in this country with, tax money. And the US went, no. We're going to have these big companies that don't know medicine, that are not run by doctors, make, AKA the insurance companies, make these really profound decisions for people's lives. I mean, I don't know the history of that. I will just say that it's unprecedented when we compare it to other comparably rich countries, that we don't prioritize universal healthcare. And it might change soon. I mean, we talk about it, right? But I think, addressing accessibility and affordability are paramount. But I think more important than those two is just addressing outcomes, right? Like, would you rather wait for someone who's excellent or get fast, bad care, right? Like, we need to prioritize it actually being good care. And I don't know the main differences which make us worse at care than the other countries, like why we finished last in that study. But I was reading another thing in the Atlantic last night, and it said that like life expectancy, as we know, is dropping in the United States in the last couple of years, which is pretty astonishing. But also that when we compare like even rich Americans with like poor Western Europeans, like poor Western Europeans live just as long or longer, meaning it's not all like, some people just think it's socioeconomic, right? Like richer people do better. And it's like, no, not necessarily. Like there's something in our system that is really preventing good health outcomes. And yeah, getting more access is important, but there really needs to be a profound kind of reimagining of our system if we want better outcomes, because like I said before, I think medicine is really important. I think it really affects people's lives. And I'd like to live in a country where, as another study just showed, half of Americans are living in chronic pain. Like, I'd like to live in a country where like that number is much, much smaller, because I think when you're in a lot of pain, and I think you experience this with your injuries, and I've experienced them with my musculoskeletal and non-musculoskeletal problems, like people are suffering, right? And like, I had years of back pain that was at times horrible, and I couldn't run and I couldn't play basketball. And I was a PT, right? And I paid for several physical therapists, and we strengthened my hip. We released my scar tissue, quote unquote, in my right low back. We realigned my pelvis, quote unquote. And they helped for a month, right? But it came back. And so like, I just get so passionate about us doing better as a profession, because I see it in my patients and I see it in me. Like, people's lives are really demonstrably affected by living with musculoskeletal problems, right? Like, not being able to walk without pain is a big deal. Not being able to sit or sleep or do your activities you enjoy, they really affect quality of life, right? And I don't think people, I don't know, maybe they do grasp that, but I don't think they grasp it enough to be like, how do we get better? Like, how do we really get better at helping people? I mean, you had low back pain. Were you a gymnast? Did I hear correctly before?
Yeah. I started with low back pain when I was 11 years old.
And how many years did it take to really get a handle on that?
Oh, many years. Going to doctors and MRIs and injections and all of that. And it was just really until I was older, and then I became a PT, and it's still going to many doctors and that thing, you got to strengthen your core, extend your lower back muscles. And then when I started doing McKenzie, that was really start understanding my pain and what to do. And then I went to consult with my colleagues that one of them now is McKenzie diplomat in Brazil. So he helped me a lot. I was always going there. So what do you think? And then he would assess me. And then I understood and learned how to deal with my pain. And then I know what to do because it's hard for us to assess ourselves sometimes. So, but yeah, many years. And so many people that I see and patients, friends calling, oh, I feel this and this, should I go to the doctor? I was like, well, what are you gonna do? They're gonna ask you, give you some pills, ask you an MRI and give you PT. So let's just assess and see if we can help this faster and quicker. So yeah.
And just as important as being able to help quite quickly with getting pain and function better is giving people that understanding. Because if you understand, and I don't even use the word derangement with patients, right? We can have a whole nother conversation about why people hate the word derangement. I love the word derangement. I think it's apropos. But when I talk with patients, I say, your joint's a little stuck, your joint's a little irritated, you need to get it moving better. Language that is not, scary whatsoever. But being able to provide that to patients is so key, right? Because if someone says, okay, I know my neck hurts so much, but Mariana just said it's a small problem that will self-resolve and usually just with movements. And now I understand how my daily activities and postures affect it. Like taking away that fear quickly. And I know I just listened to your podcast with Adrienne Turner. She was saying that too, like our job, like if you have the right tools, we can confidently take away people's fears, right? We're not just saying you're going to be better because that's what we hope for. We're saying you're going to be better because we know if we move you in this direction, we see substantial changes. And obviously not all patients are derangements, but the large, 70 to 8% are. So I think, when you can help those people, it's not just, oh, we're going to diminish your pain by 50% in a week. It's, you're just not going to spend the next week super scared, right? That, you have cancer or that you have a broken bone or that you have a disc herniation or that's something that's going to be plaguing you for the rest of your life. I had a patient recently who said to me, I really want to learn you're going to teach me how this will never happen again, right? And I was like, no, this will happen again. You want to create the correct expectations. I was like, this is going to happen again in a couple of years when you go on vacation to Hawaii and you sit in a lounge chair for 8 hours and you forget what your PT from years ago told you, but it's going to be small and you're going to be able to self-resolve it. And the odds of you ever needing medical care again are small. And if you do, it's going to be quick, a faster resolution, even though this time I'm only seeing him 3 visits, but you want to create those expectations. You don't want to have this false idea that it's never going to hurt again, because I feel like human nature, people don't follow my instructions until it comes back, right? I don't know if your experience is the same way, but it took me years to learn this, where I tell people, all right, it's like brushing your teeth every couple, twice a day, possibly. That's just a rough average of how much you'll need your, directional preference exercise. Posture is important. And it'll mostly stay away, right? And then they don't do it, and then it comes back, and then they're like, oh, she was right. Like, I really have to kind of stay on top of this. And at first, I think a PT might find that, or even a doctor might find that too much to tell a patient for the rest of their life. They're going to have to keep on top of it. But that's what health is, right? Like if you have diabetes, you're going to have to stay on top of your diet for the rest of your life. If you have a whatever disorder, like you have to do little things to stay on top of it. And I just think that at first I thought that was maybe asking too much, but now I'm like, no, that's absolutely appropriate. Like I've had a low back derangement, right? So I need to stay on top of my low back. But do I need to move my ankle every single day? No, I mean, I want to, I move, I spend time in the elevator when I have nothing else to do, just doing some loaded dorsiflexion. But you're not going to have to stay on top of every single joint and every single muscle in your body. There's general parameters for that kind of health. But for your problem, you're going to have to stay on top of it.
Yeah, absolutely. And then I think it comes the prevention, but that's another factor that it's important. And a lot of times people don't put value on prevention. I see it's not common to go to PT once once every couple of months, try to see if everything is moving fine. I'm feeling a little stiff. What do I do? And the PT instruct the patient like, well, to prevent this from happening again, doing this, this, and this. And then not just in the PT world, but like on medicine as well. We go to the doctors often to get like the physicals and do all the exams and try to prevent and see. And sometimes I see the difference in simple medical procedures in Brazil. And here, for example, some doctors there, they recommend every year you have to come back and do this, this, and this again. And here it's a little bit more spaced. It's like 2 or 3 years you come back, or once every 5 years, you're going to do this type of exams. So I think that's another thing in PT and then in medicine as well, the prevention factor that I don't think people put a lot of value.
Yeah. And I think that also speaks to what we were talking about earlier. Like if you're an American and your health insurance is tied to your job, you change jobs, you often have to find a new PCP. Like there's so many barriers to having that regular preventative care, or your insurance plan changes in your job, or your PCP changes insurance plans that they take. There's a lot of barriers to continuity. And I think continuity is kind of essential for prevention, right? You want someone who understands your health history. And you're right. I mean, we could have a world where you get a visit to your, musculoskeletal clinician, and they can give you some prevention techniques every year. Like, oh, I'm seeing that you're losing a lot of motion in your shoulder. If you want to say, get a little bit healthier, I recommend moving your shoulder like this, because stiffness is usually a predictor of pain down the road. Even though it's just stiff now, or even though you don't even feel it, but you lost that motion was given to you when you were born for a reason. Like your hip should extend, right? Your shoulder should go into functional IR pretty significantly. I think that would be great. I don't think it's ever going to happen, but yeah, I mean, those talks go a long way. And I think the MDT lens is really set up to allow that to be successful, right? Because in our paradigm, we see that stiffness usually is a precursor for pain or loss of motion, right? I don't know what a typical PT would do. Maybe they would just strength train and measure range of motion, or strength test and measure range of motion and give some ideas, right? But I think we could give more specific ideas, like, oh, shoulders usually need this, right? When this is present, when this loss of motion is present. I mean, obviously we want people to be strong, but I think, focusing more on strength versus mobility is kind of missing the mark.
Yeah, and then we were just talking about the orthopedic word. How, in your opinion, poor care in orthopedics parallels poor care in non-orthopedic medicine? Yeah,
I think what's kind of unique to my understanding of MDT is how much it's influenced from me being a patient in the United States. I mean, I was a patient a little bit in Korea when I lived there, and I want to do a post about this. When I lived in Korea, I had really bad knee pain, and my x-ray cost $2, right? Like that's probably what it costs like in Brazil, right? So we know that there's different things out there, but I had experience being a knee pain patient in the United States. And then I've had, obviously my back episode. And then I've had a lot of experience being a patient in non-musculoskeletal care in this country, unfortunately. And whereas at first I kind of, I wasn't fully into MDT, I didn't see its value until after a couple of years of really getting good at the system. But now I just see how the refusal of kind of accepting MDT is what we're doing in the rest of medicine. I've been to so many different doctors, but I went to one doctor who, took a brief history where she wasn't really asking specific questions that I think would actually like lead her diagnostic mind in different directions. And she's like, okay, let's get a picture. And I was like, okay, we'll get a picture of XYZ. And then on my second visit, she's like, okay, well, the picture's negative. So I think your problems are just due to stress. And like, I almost lost it, because I was like, this is proof to me that it's not just musculoskeletal care, orthopedic care, it's all care in the United States. Like, they just so focus on structure, right? And they don't ask the right questions. And if they don't understand it in a visit, they like make up something about how I'm having all these symptoms because of stress, which is like ridiculous and offensive, right? And angering and makes you really sad. And I just like, having gone through that experience for years, I just see like, yeah, like that's what we're doing in orthopedics. And that gives me further kind of drive to counter that and be like, orthopedics is focusing on structure with imaging as well. And then they want to make things, central somatization, I can't even say that word, or, chronic pain syndromes. And I think, yes, those exist in people. I think they exist in the other population, which is why I'm, trying to study more about pain neuroscience education. But to lump people into that without giving them a proper, mechanical evaluation, or what I would say just a good orthopedic evaluation, is just really doing them a disservice, because we have MDT studies that show, cohorts of people who have had pain for decades are mechanical, right? And so I just get further, like I said, further kind of aware of the power of MDT when I see like, oh yeah, it's the same thing in orthopedics as other things. Like, we're just focusing on structure and muscles and things we can see, and we're not understanding that pictures can be helpful in some cases, but they're not telling you how the body is functioning. And MDT really stresses that most problems are functional, right? Joints not functioning right, joints that are structurally sound are just not functioning right, tendons that are structurally sound, or maybe a little bit, a few changes on ultrasound or MRI, but they're fine, they're just not functioning right. And when you take joints and tendons that don't function well, that's 85% of orthopedics, right? I mean, you're not getting ligament tears and muscle tears and fractures in a lot of people, right? You're getting them more in highly active or athletic populations, but you're just not, right? But we're finding all those little things on images and just giving people the wrong diagnosis to start with.
Yeah, absolutely. And then I think that that plays the part in the doctor's knowledge, because sometimes I have the same feeling that you go to the doctor, orthopedic, they're going to do an MRI, see if there is something really wrong, give an injection, sometimes give you PT, sometimes not. And that's it. Like sometimes I remember when I was in PT school, I went to a doctor and I had like hip pain. And then he said like, well, you are a physical therapist, you know better than me. And he didn't say anything. Like, sometimes it feels that they don't really know what to do. They have that, they can do surgery sometimes, some of the doctors. And then the others, that's what they're gonna do, check if you have any fracture, and then give you some pain pills and recommend you PT or not. And that's it. And you were like, what?
Right. Yeah. And I think some people might be like, well, aren't we doing fewer MRIs because the evidence is actually there that they're showing false positives, or they're showing findings and not diagnoses? And I'm like, no, like in my experience, no, they're prescribed just as often. Like, I just don't see a correlation with research and practice. And obviously my lens is not huge. I'm not running a big hospital, or I'm not even involved in a big hospital or system, but I see patients, right? And like, I see patients like last week who had arm weakness, which in a young, healthy male, you're like, okay, it's either shoulder derangement or cervical or thoracic derangement, right? Like, that's what you're thinking, right? Meaning a joint's not working right, muscle activity is not firing. And he was very weak, and it resolved with, we did 40 cervical retractions and extensions. But my point is, he already had an MRI, he already had a nerve conduction test. This is a male in his 20s who's healthy, presenting with arm weakness with no pain. So we're not, obviously differential diagnosing does not tell us that he has a heart attack or something, right? But even though the evidence would probably or would almost certainly support the idea that he doesn't need advanced imaging, he doesn't need a nerve conduction test, he needs someone to like figure out by moving him what's going on, he still gets it, right? And it matters because we know people get false ideas of the quality of their spine when they see these MRIs, and they get false ideas of how bad the situation is, right? And then obviously there's the payments. Like even if that patient is only paying a $100 deductible or whatever it would be, I don't know, copay for that MRI, like as a society, those costs get attributed to all of us, right? Like, because if there's more money going for those things, there's less money for things to go to what he really needs.
Yeah, no, yeah, absolutely. And I had many experience with patients as well. Doctors referring surgeries right off the bat. And sometimes even I had, that happened in Brazil with my uncle, and he was with back pain, and he got an MRI and then showed something on his thoracic. And then I went to see, he's like, yeah, I'm going to do surgery. I was like, what, really? Let me take a look at what's going on. And then I saw his MRI and I saw the results on his thoracic. I was like, well, are you feeling pain? And I showed the area. He's like, no, my pain is on the lower back. And I was like, really? So it's so crazy that people are so oriented by MRI and not even the clinical symptoms. So his pain was in his lower back, not in his thoracic. And he had a surgery request for his thoracic. So that's, for me, is just insane, because he was about to do something that was not even the source of his pain, a completely different area, a lot of risk involved, not necessary. So it's just how the system works.
Yeah, and it's important to point out that there's reasons why we're against unnecessary surgery, right? I mean, the risk compared to movement, in that comparison is astronomical. Like, you're anesthetized, you're cut into, there's, possibility of infection. I've seen post-surgical infections, like there's risk. And then in addition to the risk, there's no certainty that it's going to be beneficial. I mean, in that case, right? I mean, I don't know what its outcome was, but I mean, there's a reason to be against these things. And I read so much literature that shows, like, even that famous or semi-famous, maybe I'm the only person who read it, but that James Andrews study of major league pitchers a couple of years ago. I mean, he took fully functional, pain-free, professional baseball pitchers and MRI'd their shoulders and found all sorts of things. And you think that kind of study would like alert orthopedists who treat shoulders, like, wow, like people who are doing really aggressive things with their shoulder have tons of findings on images but are totally pain-free. And I just don't feel like I see that really informing how practice is carried out. And on LinkedIn and all these things, you read all these studies, Achilles problems found in dancers on ultrasound with no pain. And I'm like, I'm reading this stuff, but are people who are actually prescribing images reading this stuff? And if they are, do they care? I mean, in the worst case scenario, they're reading them, they know exactly what is going on, but they're prescribing them for medicine. Like, that's the worst, or excuse me, for money. That's the worst case scenario. And I think in some cases that exists, like, I think we know what surgical departments bring in compared to conservative care departments.
And then not to mention that the patients are going to have to do PT after the surgery anyway. So that's what I guess people just think it's magic. You're going to have a surgery and it's going to be fine, but you're going to have to do PT anyway. So, yeah.
Right. I mean, what if 10 hours of someone's orthopedic care was surgery and 10 hours of someone's orthopedic care was PT? Should we get paid the same? I mean, like, we're not going to have the financial discussion, right? But just, you're absolutely right. Like, it's not a one-off. Like, if you just do a surgery and go home, like, good luck. You need an expert, PT, chiro, DO, whomever. You need an expert that understands the musculoskeletal system to not only fix the negative effects of surgery, right? Because so much of post-surgical care is just like teaching about post-surgical healing, right? Because you just had a major trauma to your body, but then you might also be addressing the real underlying issue.
Yeah. And not even the cases that they have surgeries to have pain, and then you go into the derangement, and then after all of that, the patient gets better. That's so frustrating.
Yeah. And it's just, we see that. I've seen people who have rotator cuff surgeries, who have cervicogenic shoulder pain, but they just like refuse to believe me. I'm like,
Yeah.
I showed you with retraction that all your shoulder pain went away. And like, I can just remember this one patient so vividly because it was upsetting, and he's like had his surgeon buddy on speed dial, like, this was one of the best surgeons in the South. And I was like, okay. I obviously I don't speak that flippantly with him, but I'm just like, all right, well, when we move your neck like this, what happens? And you have to walk that line because you'll completely lose patients if you're just like, obviously you didn't need shoulder surgery. And that's not something I voiced to him. But I was trying to get him to do neck exercises because it was obviously changing his pain presentation, which he was still in a lot of pain. And he ended up having an infection after his shoulder surgery too. So going back to our earlier point, like we get upset because there's risk. I can picture him sitting in his chair with like, I don't know if there's a wound vac, but something pretty intense, to treat that infection. And, that could have been avoided. That could have been avoided if he had seen a clinician who was like, you're a male over 60, you have a rotator cuff tear on imaging, if you even get to imaging, right? Like that's common. But we find a lot of these people with shoulder pain actually have simple problems in their neck that respond to movement. Like if he had seen that clinician first, regardless of the clinician's title, he has a very different outcome.
I think that would be the dream if everybody would have a chance to have that assessment prior to doing anything else. I think that would be our
you and I are
perfect word.
We're case examples for that, right? Like I would have, if in 2007, when it felt like someone shot me in my right low back after sitting in a bucket car seat for 16 hours the previous 2 days, which only in retrospect do I understand was what created the massive derangement. If I had seen someone in 2007 who was like, oh, we got this, like it's probably going to take a couple weeks or a couple months, but we'll get this thing fixed right away, it would have really changed things, and for you as well. Like if you were 11 years old and someone's like forces your parents to come in and really listen and do the things at home that they ask you to do, and this is how joints work, and this is how nerves work and muscles, and core strength is good, but it's not your problem right now, like your core is strong, like it would have changed your teenage years.
Yeah, and it has so much value. Sometimes it's so simple, and even for us, we feel that's so simple, but the impact that we can have in people's lives is massive, and I don't think we even realize how much we could impact people's life.
I do, right? You do.
Yeah.
And I think a lot of really skilled MDT clinicians do. And earlier you alluded to clinicians like not having the time to implement what they learn, but it's also the people who go to one course and reject it, which I think is a lot. And it's like going to like your DPT is 3 years basically full time. It's like going to the first semester and be like, it doesn't work, right? Like course one is just the beginning. And I will say, like, using that word simple is both a blessing and a curse, right? Elbow extension is simple, right? Repeated plantar flexion is simple. Obviously getting there is not simple, right? Like eating real food is simple, but try getting Americans not to eat 60% of their diet from ultra processed food. Like good luck in this country, right? So many of these things are simple, but the knowledge to get there is actually really hard.
Absolutely. And even from other PTs, I heard for other very experienced PTs that they were like, if I have something on my shoulder, I need to mobilize it. Like even between PTs, sometimes they don't get exactly what Mackenzie is at the potential of Mackenzie. And many PTs think it's just the spine. So it's just everything, all the education between patients and doctors, and even between PTs that they do, like you said, part A, part B. It was like, okay, I see what this is going. And they don't really go through the full process and don't really understand. And even them, like they don't realize how can you treat something using the method.
Hard. Right?
Yeah, it is.
I'm not calling you or me extremely special, but it takes a special person to spend weekends going to different courses, paying for travel, paying for hotels, paying for rental cars, and then to be like, okay, this is very different than what I've already learned, but I see some truth in it and I'm going to pursue it. I mean, if that takes a person that's not average, right? And like I worked with some amazing clinicians, but one that I thought were extremely intelligent and caring and critical thinkers. And when I came back to the clinic and I was the only one of 8 who had done any MDT training, I was like, this isn't going to work. You know, I mean, obviously, a lot of times people have to make it work, right? But I had the ability to be like, I'm going to try to do this by myself, right? But it's hard. It's hard. And I think that's why we need some support from academia, right? Because that person who's out working, who has to take the onus on him or herself to go to these courses and study, and like me, go observe mentors when you travel and watch tons of videos. Although I'll say a lot of YouTube Mackenzie videos are not where you should be getting your information from, right? I mean, I can nitpick a lot of them. I mean, they're good, but some of them are just misleading. But it takes a person that has a special level of interest in helping people, or maybe even helping themselves. I mean, if the gateway to learning MDT to help patients is helping yourself because you've had knee pain for 10 years, like that's great, right? But if academia kind of supported this, and I think some of the chiropractic colleges are incorporating more MDT, and I have a feeling they're gonna leave physical therapy in the dust if they're getting a lot of graduates from chiropractic colleges who are really skilled. Like, I think you're gonna eventually see more people being like, well, PT is just strengthening my core, but these chiros are teaching me how to move my body and get better in 5 visits. I mean, that's probably a long way off because I think there's a lot more DPT graduates than DC graduates. I'm not quite sure. But I think if we had academia teaching this, right, or at least introducing people to this. I mean, I was not introduced to MDT in graduate school. I don't know. You said you were, right?
Yeah, it was like extension exercises. Yeah.
Right. So you weren't.
At least I heard about it.
Yeah. I mean, it's almost though that you got a negative impression, right? Because you're gonna hurt some people. Like you're gonna hurt relevant laterals with extension, right? I mean, I've shifted myself just by doing too much extension, right? But yeah, and I don't know. I mean, I had this small LinkedIn conversation recently, and the woman's like, you know, I showed a video of the gentleman rapidly resolving his shoulder derangement with repeated IR, you know, and standing against the wall with a little bit of abduction. And I think she was being pleasant, but she's like, well, if MDT is so great, why isn't it taught in the schools? And I was like, great question, you know, like, I was like, I think it's egotism, I think it's incentives, and I think it's just being closed-minded. And she responded like, I don't think the university would like you to be calling them egotistical. And I was like, I am, like I am calling them egotistical, you know, because like it's something I want to fight. Like, I mean, I'm nobody in the world of medicine in the United States, right? That's a given. But like personally with my patients, like I'm going to fight for them. And like, I want them to have excellent care, right? And I want universities to adopt this so that more people have a fighting chance to help people, not just quickly, because like we understand that derangements are fast, but like it's a different understanding of the body, right? And I would argue that some people argue that, you know, if you learn a technique and it works for you, and you learn a technique and it works for you, that's wonderful. And I kind of refuse that idea. I think there's one best way to understand how the body works. Like, you know, there's the different hypotheses about cholesterol. I think one of them is better than the other. I don't think they both work, right? And there's different hypotheses about why people get sick. And I think there's a better hypothesis. And I'm open to something coming along and saying, you know, that joint derangement idea, it's wrong. I can get people better in 2 visits with them doing things. I want to learn that, you know, like I think there's a way to understand the body correctly. And I think Robin McKenzie got it right in terms of how joints move, and he accepted the other ideas of how tendinopathies work, right? Like no one's refusing that those things exist, but I'm refusing that I think a lot of people have these syndromes of patellofemoral pain and iliotibial band and subacromial shoulder impingement syndromes. And I think if you put them up against each other, the MDT hypothesis of joint derangements works better. And I don't know how I got on this tangent, but I just think academia, you know, if we start learning it there, it'll really help.
Yeah, we can go on and on and on.
Mariana, don't get me started. I mean, clearly, like, you and I both care. Like, we wouldn't be spending our free time talking about this if we didn't care. And it's just for like patients, you know, it's just for having people like really truly suffer less.
Yeah. That should be the goal of everybody on the healthcare, right?
Right. And if you're a healthcare provider and you're averaging 8 visits and you think you're doing a great job, I will say you're probably doing a pretty good job, but there's people out there who are doing better, right? And like, you know, like that matters. I think getting someone better in 5 visits is better than 7. And I think getting someone better with 1 movement is better than getting them better with 4 movements. Like, and thirdly, I think getting someone better where you don't have to touch them is better than getting someone better with manual therapy. Like, I don't know why those are debated, right? Like, they are though, right? And I'm just like, okay, we have different priorities. Like, I really think it's important for the bulk of patients to teach them independence, right? Because that's just really how you generate long-term stuff. And it's like, we don't have medical doctors going to your house and feeding you 3 times a day. Like, teach the patients how to choose what foods they put in their mouths and how to make the air cleaner that they breathe and how to sleep better. And we need to teach people how to move better.
Yeah, but I already heard from previous patients, they were like, I've been dealing with this for years. And 1 visit, I'm like 90% better. You're not going to make money. Like you have to, you know, keep patients coming back, hold them for more visits. It was like, that is when it's a lot of people's mind, then you have to, you can't just get them better with 1, 2, 3 visits. You got to keep them coming, because how you're going to survive? It's just the way people think, very different from, I don't know, what I believe, that it's, if you get people better quicker, they're going to talk about you to other people, and then another people are going to come. It's not like I'm going to hold this person here for 10 visits because I want the money, I want make more money. It's just that sometimes it's what is in people's minds. So
yeah, for sure.
Okay, let's transition then to the final questions. What is your favorite resource of information? Any books, specific studies that you would like to share?
Yeah, I just think, I mean, your prior guests have named a lot of different things that are really important, but I would say, and I mentioned this earlier, like reading case studies will take you 10 minutes, right? Read the one on the shoulder, read the one on Morton's neuroma, read the one on lateral epicondylgia, the ankle. Like, yes, case reports do not hold the research weight of randomized controlled studies, but they will give you a really good idea. I think they're clear, they're short. You can be like, oh, okay, they move the shoulder like this. I think they're a great resource for people who are getting into MDT.
Awesome. And what would be the best advice that you give to clinicians that are starting their careers?
Yeah, keep an open mind. I mean, and understand that what you were taught in school, like maybe with the best intentions, is not going to necessarily yield the best result. And that's not just, you know, physical therapy or orthopedics, that's all of medicine. Things evolve. And so my best advice is to just go to different courses, you know, go to Mulligan, go to Maitland, go to, I guess, Stanley Paris's courses or whatever. I mean, I've been to a lot of them, and kind of really be critical about what works the best.
Yeah. And what do you think are the best qualities and abilities a PT should have, personal qualities and abilities, to become a successful PT?
Yeah, I mean, I think there's a lot of them, but at the foundation, to be the best PT, you just have to really care. I mean, you have to care about, I mean, if your job is to help people resolve their musculoskeletal disorders, like, you need to care about how to do that the best. And like, that's not a quality that you can necessarily teach people, right? I think that has to be in them. And I think it is in people when they go and decide to write the first tuition check for their DPT program. Like, I think people do care, but I would argue that I think some of that wanes, right? Or they get to a point where they're helping people pretty well, but they don't keep seeking other alternatives that would help them even better, right? So I guess that constant interest in just being really good at your job.
Yeah, absolutely. Laura, for the ones that want to learn more about you or contact you, or if you have any questions, is there a way that they can reach you?
Yeah, sure. I'm on Instagram, Dr. Laura Mannery. I'm on Facebook, Laura Mannery Physical Therapy. Those have ways to contact me with any questions. And I try to post, I post almost daily some information. And yes, of course, it's MDT heavy because that's the kind of information I want to get out there. But it's not always about MDT. And I try to just get things out to the public that, not necessarily clinicians, but the public can be like, oh, yeah, this doesn't make sense that my other doctor said this is what's going on. So yeah, social media is a good way to find me.
Yeah, I follow her. She has very good posts. She's always putting a lot of good information there. So follow her. I especially follow her on LinkedIn, but I know you have Instagram and all of that. She's always putting a lot of good stuff. So I highly recommend you to follow her. And Laura, thank you so much for your time, for being here with this discussion that we had. We can keep going here on and on because we have so much to talk about. But that was great. It was an awesome discussion.
We might meet someday at a course when courses are in person again. That would be fun.
Yeah, absolutely. Well, I really appreciate you taking the time, Laura.
Yeah, thanks for having me.